So the SURPASS trial is actually a confirmatory study. It's ongoing. It is looking at patients with a certain type of characteristic with malignancy-associated hemophagocytic lymphohistiocytosis. The study that led to this phase 2 registration is a phase 1 and a phase 1b study of a pan-SIRP, SIRP, pan-SIRP inhibitor called ELA26 in secondary HLH. And I'll talk about that in a second. But this pan-SIRP inhibitor inhibits the SIRP, which is expressed on macrophages and activated T cells, which we know is the basis for this uncontrolled inflammation that happens in HLH. Essentially, it's a four-step process of T cell dysfunction, followed by macrophage overcompensation and activation, and the two get together, lead to a chaotic situation where a lot of cytokines are released, and this sort of adds fuel to the fire, if you will, leading to organ damage. So these four steps leads to what we now know as hemophagocytic lymphohistiocytosis, because the macrophages start eating up the other cells, and with this end organ damage. The ELA26 is a pan-SIRP inhibitor I mentioned, depletes these activated T cells and the macrophages, and obviously it affects the biology and tries to change the biology. Thus far, all the treatments we've had for HLH included chemotherapy, sometimes treating the cancer. If it's malignancy-associated HLH, you could get the HLH under control. But now there's enough data to show that, particularly in lymphomas such as T cell lymphomas, certain leukemias, treating them with chemotherapy may not help. It may actually make things worse. And some chemo agents like etoposide in the past has helped, along with steroids. But in the advent of anti-cytokine therapies like tocilizumab, which is an anti-IL-6 antibody, along with anakinra, which is an IL-1 beta antibody, have shown some control of this inflammatory process. If you talked about those four steps, so it controls the cytokine production to some extent, but it doesn't address the cause. And the main cytokine that drives all these things is interferon gamma. Interferon gamma is the main culprit that sort of colludes the connectivity between the macrophages and the T cells and the release of all these different cytokines. So there is an anti-interferon antibody, emapalumab, which is approved for primary HLH, and one type of secondary HLH called as juvenile arthritis-associated HLH, or MAS, macrophage activation syndrome. That being said, for malignancy-associated HLH, which is a different entity where you have HLH in the setting of cancer, there are no agents, no drugs, and chemotherapy is, as I mentioned, makes things worse. Steroids and decadron or prednisone help to some extent. So that's the context in with which we studied the ELA26 in the phase 1, phase 1b. And based on those studies, we had 3 cohorts in that study. One to test the safety as a first cohort, along with intrapatient dose escalation. Second was to try and get some variations in the dosing based on the pharmacokinetics. And at that time, we actually had relapsed refractory patients enrolled, and they actually did well. And this has been presented several times, including a late-breaking abstract at EHA last year, and also ASH oral presentation last year. And we also had a Lugano presentation of a subset of patients who had the lymphoma, were treated with ELA26. And we found that actually not only treats HLH, but also treats the lymphoma, whether it's a T or a B cell lymphoma. And more importantly, when we looked at a cohort of patients in the third cohort with early diagnosis of HLH, their survival was close to 100%. And I have to set this background. Clinically, HLH, why it is devastating is the median survival is less than a couple of months. And the 6-week survival is about 30%. So if you look at those data sets, the ELA26, of course, it's a single arm study. It's a phase 1b study. Everyone that is enrolled crossed that 6-week mark with 100% survival. And we still have patients who were treated on the study who are still have no evidence of HLH or no evidence of lymphoma. So that is the context to the SURPASS study. The SURPASS study is a registration study that is it's ongoing. It's looking to enroll patients with HLH, secondary HLH, and there are 2 cohorts. The cohort A is mainly lymphoma, and there are about 47 patients at the lymphoma cohort. And cohort B are other forms of secondary HLH that includes immunodeficiency, includes HLH due to infections, HLH due to autoimmune diseases. It also includes a cohort of pediatric patients because we do see HLH as a problem in pediatrics. And what we didn't talk about is the pediatric patients, the driver, the pathophysiology is dependent on certain types of mutations in the T cell genes, which control the activity of the T cells through granzymes and perforins. And those genes, when they are mutated, that can lead to HLH, and that's called primary HLH. So there are cohorts of patients in the pediatric age group that can be treated with emapalumab, which is the anti-interferon gamma antibody, but many of them do relapse, and so there's an opportunity to consider those patients on this cohort B. So SURPASS is all-encompassing. There is also a companion protocol called the COMPASS. The COMPASS is a natural history study, and since it's a registration study, it's a single-arm study, there was the sense that we need to have some kind of a control, and the best control is a simultaneously collected data, even though it's retrospective, simultaneously collected data on patients with similar eligibility as the SURPASS study. And at some point, both the data sets can be compared. So that way we have the right controls that can be matched in the right way. We use something called propensity matching. And when that happens, you have a comparator arm, because it's a very hard study to conceive as a randomized study, because the numbers are so few and far in between. You may have 1 in 5,000 patients that might get diagnosed. So for that reason, doing a randomized study may not be as helpful. So this is one way of getting around it. So all in all, it's a well-designed, well-thought-out studies, both SURPASS, which is the intervention study, and the COMPASS, which provides the map or the background, the historical controls in a propensity match setting to give us a good sense of how well this ELA26 will do compared to all the historical therapies that I just alluded to. Great question. Mind you, these are patients with HLH who have very low counts, so they're cytopenic, profoundly cytopenic. The liver enzymes are elevated. The clotting proteins are very low, like fibrinogen, and the ferritin and the cytokines are sky high. So that's the context, and they're all they all have a fever. So and this study allowed patients to get chemotherapy. So it's a little bit of a cloudy, confounded situation with many things going on. In that context, ELA26 was very well tolerated. The main thing that we saw in the cohort 1 was the infusion reaction, and the infusion reaction was mainly because the way it was given, and we overcame that by giving steroid-free medications. And with subsequent dosing, it improved, and patients are actually allowed to go on to get sub-Q injections thereafter as an outpatient. So that's one thing that we've seen, at least initially. And we still do see, and when that happens, it's like a lot of other monoclonal antibodies. We have the pre-medications, and we have to stretch the duration of infusion. Second is cytopenias. The cytopenias sometimes can get worse before they get better, especially platelets and the neutrophil counts. So they stay low for some time, and then they pick up once you see the clearing of the bone marrow. These two are probably the most important things. A lot of other things that we saw, infections that could happen because of the neutrophils being low, are a consequence of the low neutrophils and may not be a direct effect of the ELA26. One thing, what we're trying to do is create the awareness. There's something called HLH, which is devastating. We need to recognize this early. And obviously, and it's not that people are clinicians are not recognizing this. It's just that we don't have any effective therapies. So one thing that will come out of the study is that if you recognize there's a need to have the exercise for HLH criteria, you also have a potentially effective therapy that can save lives. So keep that in mind. So keep the keep the high index of suspicions for HLH, and if you have patients, please send them to the centers around you. It's an international study. It's not just in the US, but also in UK and a few sites in Europe. So please send patients to participate in the study.